Hello and welcome to the 8th ASPA FLEX2 webinar. The topic for today's webinar is anesthesia for plastic surgery. In the next 1.5 hours, we hope to have our panel of experts share with you the unique challenges related to craniofacial surgery and burns management. In addition to our invited speakers, we also have a guest panelist today, Dr. Serene Lim. She is a senior consultant with the Department of Pediatric Anaesthesia in KK Women's and Children's Hospital in Singapore. She is a pain specialist and is one of the key figures in the setup of the pain management protocol in the KKH nurse-led burns management service. I am Dr. Josephine Tan, and I'm also a colleague of Dr. Serene Lim in the KK Women's and Children's Hospital. And together with Dr. Ritu Prahan, Chief Consultant Anaesthesiologist, Head Department of Anaesthesiology and Intensive Care in NAMS Veer Hospital in Nepal, and Dr. Teddy Fabulos, we will be your moderators for today's webinar. Dr. Vibhavari Naik is our IT support for today, without which the webinar will not be possible. Before we start the webinar, I will share some housekeeping instructions. If you have any questions or comments for the speakers, you may post your questions and comments in the Q&A section. Please note that the chat and raise hand function have been disabled. Your questions in the Q&A section will either be answered directly within the Q&A section or will be taken live by the speakers at the end of the talk. Certificate of attendance will be generated and emailed to those who have submitted the post-webinar survey. The post-webinar survey will be emailed to you tomorrow on the 22nd of August at 5 p.m. Singapore time. Please ensure you key in your full name and email address. The webinar will be recorded and made available for future viewing at our ASPA website, Facebook, and YouTube. During the course of the talks, poll questions may be posted. When a poll is launched, you have 30 seconds to respond and submit your answer. The answers to the poll questions will be shared once the polling is closed. Without further delay, let me introduce our first speaker, Dr. Ana Therese Bautista, otherwise known as Dr. Apples. She is the chair of the Department of Anaesthesia, Craniofacial Foundation of the Philippines, and is an anesthesia panel member and consultant on Smile Train Philippines, a non-profit organization involved with voluntary cleft surgery in remote locations. Her talk today is titled Anesthesia for Cleft Surgery, Best Practices. Let us now welcome Dr. Ana Therese.
Good afternoon. For the first poll question, we would like to ask you, you can answer any. You may have other options. For cleft surgeries, please select what you think is optimal. Apply throat pack for cleft surgeries, cuff ET tube for all cleft surgeries, throat pack for cleft lip, no throat pack for cleft palate. Thank you for answering the poll questions. As I said, it's a matter of preference, but in my talk, I would be sharing some of the studies that prefers that surgeons have questions regarding throat packs. Okay, for the next poll question. What is the most helpful scoring system or message of airway in children? Malampati classification, Cormack and Lehane, Lemon assessment, or Kapoor?
Yeah, these are the results, Dr. Apples. Should we move on to your talk?
Okay.
Thank you.
Thank you. Cleft lip and palate is one of the more common congenital malformation and the most common craniofacial anomalies in children. The treatment is expensive and requires specialized care. Access to this care in middle and low-income countries can be challenging for patients who are from the underserved, underprivileged, urban to remote rural communities. Good afternoon. I'm Dr. Apples, and I would be focusing on the best practices for cleft surgeries. I have nothing to disclose. At the end of this session, we will be able to touch on the best practices in anesthesia for cleft surgeries, as well as the difference in anesthetic care in tertiary center and that of the outreach mission. The main surgical aim for cleft surgeries is to restore the facial appearance to as near to normal as possible. And for babies, lips are important for sucking, and they are used to relay emotions such as smiling when they're happy and to pout when they're upset. With cleft palate, our goal primarily is to isolate the nasal cavity from the oral cavity. In doing so, every effort is to be made to preserve and restore the maxillary mandibular occlusion. However, efforts may result in shortening of the palate and cause velopharyngeal insufficiency. This needs to be corrected before the speech becomes too unintelligible. In 1964, an audit of American plastic surgeons established that the safe age for cleft lip repair is between 6 to 12 weeks, which later evolved to what we now know as the 10-10-10 rule. With patients weighing more than 10 pounds, with hemoglobin of more than 10 grams per deciliter, and with the white blood count of less than 10,000. Cleft lip is classically repaired between 3 to 6 months. However, with evolving safer anesthetics, monitoring, and technical advances in anesthesia and surgery, there is an increasing trend to operate earlier, provided the team of surgeons, anesthesiologists, and nursing staff are experienced in handling this special age group. Cleft palate repair is done later at a later age. Timing of repair is aimed at preventing further speech abnormalities and minimizing distortion of the facial growth, which can occur when it is done too early. Another reason for delay in cleft palate repair is the global trend, which shows that sentinel events are less likely to occur if cleft palate surgery is done in children greater than 9 months of age. The time between birth and this initial repair allows for thorough workup of other comorbidities and evaluation of any underlying syndrome. In majority of these children with a cleft, there are no other associated syndromes or malformation. However, 20 to 30% of will still have underlying syndromes or systemic abnormalities requiring evaluation and treatment prior to the repair of the cleft defects. Syndromes such as Pierre-Robin sequence, Treacher-Collins, golden hair, are associated with mandibular hyperplasia, which can potentially make airway management and repair difficult. Cardiac abnormalities are the most frequent associated comorbidity in children with cleft. Tetralogy of Fallot, atrial septal defect, and ventricular septal defect represents the most common congenital heart disease seen in this patient population, and thorough workup and optimization must be done. In the WFSA website, anesthesia tutorial on cleft lip and palate, we can find the list of these syndromes and its clinical significance in our anesthesia care. For example, the Pierre-Robin, where it shows that intubation can become easier with age due to mandibular growth. Treacher-Collins, where intubation may become more difficult with increasing age due to the hypoplasia of the zygomatic bones and mandible, and so on and so forth. Now, Jacob et al. In the oral maxillofacial surgery for the clinician in 2021 stated that in the pediatric patients, the Mallampati score does not accurately predict a poor view of the glottis, and there are no standard values for thyromental and horizontal length of the mandible. Thus, an adaptation is required, and this is found in a Cooper scale. Cooper scale uses a detailed scoring system and is therefore possibly more reliable, especially in the syndromic child, and the cooperation in children may be challenging, and the availability of this scoring system for every assessment can be of greater value. For couple scale, C stands for chin, with the normal being 1, down to the extremely hypoplastic, 4. O for opening, the difference between the internal dental space between front teeth. P for previous history of intubation or the presence of obstructive sleep apnea. U for uvula. You can see it with the mouth open and tongue out, or when the patient is crying. R stands for the range of motion for your neck mobility, and we see this with the line from eye to orbit with a range of motion looking up and down. And with the scores, we add them up, and if you have a score of 5 to 7, it predicts the easy normal intubation, and if it goes up to about 16, it signifies dangerous airway, and we should consider awake intubation and potential tracheostomy. Although cardiorespiratory arrest following cleft surgeries is relatively uncommon, post-operative cleft lip and palate repair is associated with potential risk of airway obstruction secondary to soft tissue swelling, bleeding, and if undetected, a forgotten pack may cause respiratory obstruction, respiratory failure, and subsequent cardiorespiratory arrest. Throat packs are commonly used to prevent ingestion or aspiration of blood and other debris during cleft lip and palate surgery. However, dislodgement or retainment after extubation could have a serious consequences, and it has long been a topic of debate among cleft surgeons. The advantage of inserting absorbent packing within the pharynx must be weighed against the risk of unintended retention postoperatively. Despite safety check mechanisms in place, retention may occur in potentially life-threatening consequences. A retrospective study was performed in all children who underwent cleft lip and palate surgery at the Wilhelmina Children's Hospital in the Netherlands, and they compared the period when pharyngeal packing was applied according to the hospital's protocol and the period when the pharyngeal packing was removed from the protocol. And the study concluded that omitting routine placement of throat packs in cleft lip and palate surgery was not associated with an increased early postoperative complication rate. Therefore, the traditional routine placement of throat pack during cleft lip and palate surgery can be questioned. A bigger scale review was done from December 2019 to August 2020 in all cleft surgery units in the United Kingdom and Ireland were surveyed on their use of throat packs undergoing elective cleft palate surgery. And to standardize the responses to a specific age range, they focus on throat pack usage in children aged 6 months to 2 years of age undergoing primary cleft palate repair. The UK and Irish experience provides a comprehensive appraisal of current practice regarding the use of throat packs in the cleft lip palate surgery, demonstrating that three-fourths of all units still routinely use packs, and notably, a quarter of respondents had direct experience of an incident involving a retained throat pack, which precipitated change in practice in some of the centers. Nevertheless, majority of the respondents considered the incidence of retained pack to still be low. The growing use of microcuff endotracheal tube along with recent reports on low incidence of perioperative complications when throat pack is not inserted in the presence of cuff tubes might prompt cleft surgeons to review the use of routine pharyngeal packing. Post-operative analgesia in patients undergoing cleft lip and palate repair is associated with the potential risk of reduced respiratory drive from administration of the perioperative opioids to pain control. And this residual sedation can cause respiratory depression, which, if left undetected, could lead to respiratory failure and subsequent cardiorespiratory arrest. Nerve blocks produces effective prolonged analgesia and reduces the need for post-operative opioid analgesic, thereby minimizing the potential side effect of opioid-related sedation and respiratory depression. The trigeminal nerve is the fifth and largest cranial nerve, which supplies the innervation to the masticatory muscles. And principal sensory function of the maxillary region includes the facial skin, the anterior half of the head, the nose, sinuses, and the mouth, and the anterior two-thirds of the tongue and all of the teeth. The relevant terminal cutaneous branches of the maxillary nerves are the infraorbital, zygomaticofacial nerve, zygomaticotemporal nerves. Note the exit of the infraorbital nerve from the infraorbital foramen and the location of the external nerve at the nasal dorsum. Sorry. Direct local infiltration of anesthetic is somewhat uncomfortable for awake patients and has many disadvantages, such as the requirement of multiple injections, tissue distortion, and hindering margin. So nerve blocks can lessen these advantages. This is the example of the intraoral infraorbital nerve block. Salum et al. Presented a nice photo of the external extraoral infraorbital nerve block, and this figure shows that while performing the infraorbital nerve block, infraorbital rim is palpated to avoid inadvertent injury to the globe and penetration of the foramen. The external nasal nerve block is injected bilaterally as it exits beneath the nasal bone, piercing the cartilage to supply the nasal sidewall and tip. This branch of the ophthalmic division of the trigeminal nerve, and it is not affected by the infraorbital nerve block, so the patients will feel discomfort in the nasal region if this branch is not blocked. Cleft palate is the most common and painful surgical procedure in infants and children. Its repair is associated with post-operative respiratory difficulty because of the narrowed airway, increased secretion, pain, and sedation caused by the need for opioid analgesia. The greater palatine nerve block is the anterior branch of the maxillary nerve, and it supplies the sensation of most of the hard palate in the greater palatine nerve block used for anesthetizing palatal tissues distal to the canine. It is less traumatic than the nasopalatine nerve block because the palatal tissues in the area of the injection site is not anchored to the underlying bone. The nasopalatine nerve block is anesthetizes the nasopalatine nerves bilaterally. This technique can be performed in patients with incomplete cleft palate. However, in patients with complete cleft palate where premaxilla is malformed, this block cannot be performed. A handful of studies on bilateral suprazygomatic maxillary nerve blocks showed its effectiveness to improve pain relief and decrease the need for additional opioids post-operatively. Admittedly, I have yet to try doing this block with my patients. Maybe with the advent of ultrasound-guided regional blocks, it's an option I am willing to try. So, what are some of the differences of doing cleft surgeries in mission setting and tertiary setting? For the patient selection, the goal of preoperative history, physical examination, and health clearance is to have patients with low risk in developing anesthetic and perioperative complication in the roster for mission setting. So for mission setting, we limit the patients for those patients who are under ASA1 and ASA2 physical status. Although we occasionally see ASA3 patients for screening in outreach mission with the following conditions: uncorrected stable congenital cardiac abnormality, malnourished patients, premature infant with post-conceptual age less than 60 weeks, full-term infants less than 6 weeks of age. These patients can still be done. However, we should do it in a tertiary center where the availability of high dependency care or intensive care units are available if we need it post-operatively. Outreach missions starts in Manila where we pack surgical instruments lights, cautery machines, suction machines, medications, and fluids, as well as the forms we need to accomplish. Remote or mission setting surgeries proves challenging for safe and quality anesthetic care. We need to bring our armamentum of properly calibrated functioning gadgets, from a portable anesthesia machine, anesthesia monitors with capnograph, visual laryngoscopes, and the full airway management devices. All this we pack and ship a day or two before the surgical team's departure. Let me end this session with a patient we saw and managed in a remote mission setting. He is an 11-month-old male, healthy, who came in for a repair of cleft lip, and the pediatric service assessed him as low risk, and he was diagnosed with cleft 7 with micrognathia. Once asleep, face mask was a bit challenging because of the leak through the facial cleft. So what we did was to reorient the face mask sideways and applied surgical gloves. The difficulty didn't end there. Intubation of this patient proved to be challenging even to the highly skilled, well-exposed volunteer anesthesiologists. After several tries and maneuvers of conventional laryngoscopy, we were able to intubate the patient with the aid of an older model of the visual laryngoscope, Vivid Track, and the patient cleft lip and facial reconstruction was done uneventfully thereafter. With this, I'd like to thank ASPA for having me, and have a great week ahead. Thank you. Stay safe.
Thank you. Thank you, Dr. Ana Teresa Apples, for a nice and elaborate presentation on the very challenging surgery, cleft palate and cleft lip. It was very highlighted and enlightening. Without any delay, now I'd like to introduce the next speaker. Our next speaker is Dr. Ina Ismarati Safaruddin from Malaysia. She is a professor of University of Malaya and senior consultant on University Malaya Medical Center. And she is also president of Malaysian Society of Anaesthesiology and Malaysian Society of Paediatric Anaesthesiology, with a special interest on pediatric anesthesia, airway, liver transplant, and medical education. She will be presenting on the craniosyntestic surgery, anesthetic challenge and implication. Dr. Ina, the floor is yours now. Thank you.
Hi, thank you everyone. Thank you, Dr. Ritu. Right, let us start with a question before I proceed with the lecture. First of all, what is your choice of pain management post-operatively for craniosynostosis surgery? 1, IV paracetamol, 2, scalp block, 2, 3, syrup oxycodone, and 4, all the above. The second question, which drug can we administer preoperatively to reduce bleeding in craniosynostosis surgery? First, protothrombin concentrate complex. Second, tranexamic acid. 3, factor 7. And 4, vitamin K. Thank you. Right. So we have answer for the first poll question. Many answers for the first question, many answer all the above. Well, it's no doubt that we do approach it multimodal, so it will be further detailed in the slides later. And for the drugs which we can administer preoperatively to reduce bleeding, it's interesting. Many also agrees that many have voted that tranexamic acid is the drug of choice. So let's see in my lecture. Thank you very much. Assalamualaikum and a very good evening to all. Thank you, Madam Chairperson, for the kind introduction, and thank you, Dr. Josephine Tan, for the invitation for me to share my experience in this FLEX webinar. I am Ina, and today I would like to share my thoughts on craniosynostosis surgery, anesthetic challenges and implications. This is a 1-year-old girl who presented to our hospital with a complaint of breathing difficulty due to left choanal atresia. She also complains of enlarged head associated with dilated veins on the scalp, persistent vomiting, bulging eyes, and difficulty in breathing, and always have recurrent chest infection. She was diagnosed to have a Crouzon syndrome, and she was planned for a craniosynostosis surgery. Craniosynostosis is a disorder of skull development that occurs as a result of the premature fusion of one or more cranial sutures. Incidence of craniosynostosis is approximately 1 in 2,000 live births, and it commonly presents as an isolated abnormality, but can also present as a component of identified syndrome or genetic disorder. In this particular patient, the girl was diagnosed with Crouzon syndrome, which was associated with mid-face hypoplasia, maxillary retrusion, proptosis, and hypertelorism. Patients with craniosynostosis can complain of elevated intracranial pressure, disturbance in intellectual and neurological development, mid-face hypoplasia, which is associated with obstructive sleep apnea, airway complication, exobetism, difficulty in feeding, and difficulty in speech. The indications to proceed with craniosynostosis surgery are increased intracranial pressure, severe exophthalmos, obstructive sleep apnea, craniofacial deformity, prevention of neurological sequelae, and psychosocial concerns. The timing of craniosynostosis surgery varies. It can be an emergency surgery when there is a raised ICP. On average, children benefit from early surgery as their bones are softer, more malleable, and the cranial bulk continue to grow. The disadvantages of early surgery includes the risk of anesthesia in a younger patient and the potential massive bleeding. The anesthetic management of these cases requires meticulous preoperative assessment. A multidisciplinary evaluation is required along with the usual reviewing of medical problems related to these children and to iron out all the issues including sequence of operation. In our center, the team includes the neurosurgical team, oral maxillofacial team, ENT team, the ophthalmology team, the intensive care team, the pediatrician medical team, especially the genetics team, and of course our own anesthesia team. In other center, the team will include the plastic surgeon. Other support teams include nutritionists, speech therapists, and physiotherapists. Infants with asyndromic craniosynostosis are generally healthy infants, whereas patients with syndromic craniosynostosis will have associated anomalies such as history of obstructive sleep apnea, congenital heart disease, they can have syndactyly, and they often have ongoing chest infection. These children are also often associated with difficult airway and obstructive sleep apnea. Due to anticipated difficult airway, inhalational induction with spontaneous respiration is preferable. In condition where obtaining face mask seal may be difficult, the patient might need fiber optic intubation. This can be done either asleep or under sedation. In this particular case, stage surgery with a tracheostomy was done earlier due to impending airway obstruction. After intubating the child, at induction, the ETT position should be verified in both flex, extended, and rotated head positions with auscultation or fiber optic bronchoscope. We need to make sure that the tube is not king and it can't be compressed by using reinforced tubes. The anesthetic concern intraoperatively includes bleeding, venous air embolism, intracranial hypertension, hypothermia, and the complication of positioning. Standard monitoring in accordance to American Society of Anaesthesiologists guideline is needed. These include ECG, pulse oximetry, and tidal capnography, temperature probe, and we most of the time will need invasive atrial line for stringent blood pressure monitoring and frequent blood sampling. A central venous catheter is required in anticipation of massive blood loss or for treatment of venous air embolism. Advanced monitoring like precordial Doppler is useful to detect the venous air embolism, and it should be employed whenever possible. The incidence of massive blood loss in this surgery ranges from 20% to 500% of circulating volume. The massive bleeding is due to the elevation of the vascular periosteum, in which the dural sinuses are often the source of sudden and rapid blood loss requiring immediate resuscitation with fluid or blood product. Complication of massive hemorrhage is not only related to the immediate consequence of hypovolemia, but it's also a sequelae of metabolic acidosis, dilutional coagulopathy, thrombocytopenia, hyperkalemia, hypocalcemia, and hypothermia. The factors that may predict large blood loss perioperatively include syndromic craniosynostosis, operation on patient with pansynostosis, and operation on patient with age less than 18 months, and operation which is associated with a long duration. In anticipation of bleeding, we should prepare the patient with blood and blood product in the operating theatre, and we should put at least 2 large bore of IV access to the patient. The principles of managing massive bleeding in this patient follows the principle of patient blood management. This consists of the first pillar, second pillar, and third pillar. The first pillar is optimizing the hematopoiesis, the second pillar is minimizing blood loss, and third pillar is harnessing and optimizing physiological tolerance of anemia. Hence, in patient undergoing craniosynostosis, preoperatively, if the blood volume permits, we can do preoperative autologous blood transfusion or acute normovolumic hemodilution. We can also administer recombinant erythropoietin to promote hematopoiesis. Intraoperatively, we can use intravenous tranexamic acid at 50 mg per kilogram bolus followed by an infusion. We can also use cell saver. However, the use of cell saver in younger children can be limited due to the low blood volume. Surgeon can use fibrin glue. Fibrin can be used at the site of the surgery to encourage hemostasis and reduce blood loss. Fibrin is a naturally occurring substance and has been shown to reduce the need for allogenic blood transfusions, both intraoperatively and after operation. Induced hypotension is not a widely accepted technique for blood conservation due to the increased risk of venous air embolism with low venous pressure and the potential hemodynamic instability associated with rapid blood loss. Postoperatively, it is advocated to practice restricted transfusion threshold. The transfusion trigger can be as low as 7 to 8 grams per deciliter. To avoid unnecessary blood product transfusion, the use of thromboelastographs such as Rotem is highly recommended. This is a study done on 47 children in Children's University Hospital Zurich between 2007 and 2013. A total of 47 children were analyzed. Although all the patients in the study needed transfusion of red blood cell concentrate, there was a total avoidance of perioperative transfusion of FFP and a reduction in transfused platelet after implementation of PBM strategy. In a study by the same author, Thorsten has looked at the comparison of different sources of fibrinogen. And as we know, In bleeding, fibrinogen is the first factor to go. So in order to give appropriate amount of fibrinogen, using fibrinogen concentrate is the best option as compared to the rest, as it supplies fibrinogen in a well-defined quantity and in a low volume. The other life-threatening complication is venous air embolism. It occurs when the head is positioned above the heart and the bony venous sinusoids or dural sinus are exposed. The incidence of venous air embolism in the study done by Lisa Faborowski was shown to be about 82.6%. 32 episodes of hypotension were demonstrated in 8 patients, but the good news is none of the patients developed cardiovascular collapse. So how can we detect it? It can be detected with routine precordial Doppler, which has been recommended to increase the chance of early diagnosis. However, most centers use capnography for detection. A rapid cardiovascular collapse can occur and can be translated with an acute reduction in capnograph, and the treatment for venous air embolism is predominantly supportive. Once a venous embolism is diagnosed, we should notify the surgeon and call for help. This is a crisis. Then, we should administer 100% oxygen to the patient and discontinue any nitrous oxide or volatile agent. The surgical wound should be flooded with saline and the head should be positioned below the heart. We then should perform Valsalva maneuver with manual ventilation. Chest compression should be administered even if it's not in cardiac arrest, as this may help to break the bubbles. Cardiovascular compromise should be treated with usual inotropes such as adrenaline. A standard pediatric advanced life support protocol should be followed if there's any event of cardiac arrest. A call for emergent transesophageal echocardiography to confirm the diagnosis is beneficial. Many craniofacial procedures are lengthy and careful attention to proper patient positioning is important. The patients may be positioned in supine, prone or modified positions such as a swing position. Padding of pressure points and prevention of pressure over the orbits to avoid corneal abrasion, retinal ischemia, and optic damage is required. Thus, proper care of the eyes in the form of lubrication, taping or tarsography should be done. Pressure on the neck should be avoided as it can obstruct venous return and increase the ICP. In addition, when positioning the patient, careful attention should be given to ETT and all the lines to ensure that no dislodgement occurs during this period. Intraoperatively, the large surface area of an infant's head coupled with its high perfusion, together with anesthetic effects and administration of large volume of cool intravenous fluids, can result in hypothermia. When hypothermia occurs, we can get a lot of complication. Even mild hypothermia impairs coagulation enzyme function and is associated with increased bleeding and transfusion. Therefore, it is imperative that management is directed to prevent it. We can use active warming techniques which include forced air convection blanket, circulating warm water mattress, overhead radiant lights, and fluid warmer. In our center, in addition, we will wrap the patient with autoband to prevent heat loss. Most patients are extubated at the completion of surgery. But however, there are factors that may delay extubation of a patient, which includes a prolonged procedure with marked fluid shifts. If patient needs a large volume transfusion, this also needs to be taken into account as they might have post-op complications such as Strelly or Tacos. Effects of prolonged prone position can also cause a patient to have a delayed extubation. Patient factors such as preoperative obstructive sleep apnea or airway concern also will be taken into consideration when extubating a patient. Most patients will be cared for on the ICU or high dependency units and observed for hemodynamic and volume status changes with close monitoring of hematological and coagulation profiles for the first 1 to 2 days. Post-operative pain is usually not severe. Scalp block with intermittent opioids and regular IV paracetamol can provide satisfactory post-operative analgesia. Syrup oxycodone can be administered when you want to convert IV morphine to oral form. The use of non-steroidal remains controversial as there is always an issue of bleeding post-operatively. I have come to my last slide. In summary, craniosynostosis surgeries involve risk with the potential for major intraoperative complications such as massive hemorrhage and venous air embolism. Optimal anesthetic management with meticulous preparation for blood loss replacement, proper positioning, preparation for difficult airway, and prevention of hypothermia is paramount. Multidisciplinary teamwork is very important in managing this sort of cases successfully.
Thank you very much, Dr. Ina, for that very comprehensive talk. We wish to apologize to other attendees. I think some of our attendees experienced some audio issues. We apologize for that. We are working on a way to resolve the issue. Okay, moving along. Before we proceed to our next speaker, we would like to invite everyone to please key in your questions in our Q&A box. Our speakers will answer them immediately by text, and some of it we will pull and discuss it during the Q&A session during the panel discussion. All right. So our next speaker is a senior nurse manager of plastic reconstructive and aesthetic surgery, KK Women's and Children's Hospital in Singapore. She's a preceptor, a graduate diploma in wound ostomy and continence practice students. She's also a Sing Health Wound Management Council co-chair and a committee member of ABIS, WHSS, and SNA. Sister Corinne Low is also have a great interest in pediatric burns and wound healing, pain management, ear-well infant correction system for neonates with minor ear deformity, and cleft missions. Please welcome everyone, Ms. Corinne Low, as she discusses repeated dressing for burns, the KKH protocol. Sister Corinne, please carry on.
Hello, and thank you, ASPA organizers, for inviting me here to share on my topic of repeated burns dressing, the KK Hospital protocol. I'm Corinne, and I'll be sharing the topic from the nursing perspective. Now, on this slide, it shows the number of patients dressing workload over 4 years. Pediatric patients who suffer from burns are referred to cleft and craniofacial center between 24 to 36 hours. CCRC does about 1,000 repeated dressing a year, with the numbers coming from average 28 patients referred from CE who require about 3 to 4 dressings for superficial, partial to deep partial burns. The age groups that we see are between infancy and 18 years of age, and the general patients with TBSA, or rather the total burn surface area of less than 10%, are seen as outpatient. The vast majority of these patients are below 5 years, and 75% presented with superficial partial to deep partial burns of less than 3%, mainly on the upper and lower limbs from wet burns like scalds by hot water, soup, beverages, porridge, soupy noodles, and steam. The dry heat burns comes from hot iron and oven glass. Superficial burns, partial burns wounds are usually very painful, blotchy with blisters and weepy, while the deep burns are white and leathery and relatively painless. 40 outpatient cases on average require sedation or general anesthesia to facilitate the dressing change. In 2016, the pediatric anesthetics pain team started a mobile anesthetic setup and performed GA at cleft and craniofacial center for this patient. In 2017, the work instructions on providing patient safety, effective pain management, and better patient outcomes got the dressings done in minor procedure room in day surgery. The Burn, Analgesia, and Sedation Initiative was actually jointly set up by the core pediatric pain specialists, the head of plastic surgery, plastic nurses, and supported by the pharmacists as expert resource on sedation protocol. Our policy for the department is to ensure that all new patients with burns are seen in advance, prior or on their appointment date itself, so that patients who meet the criteria for dressing under general anesthesia are scheduled for burn wound debridement and dressings. They either come on the same or the next day, or they report directly to CCRC if they reject the offer of dressings under GA. The criteria we set up are pain score above 5, burns, total burn surface area between more than 5 to less than 10%, burns involving genitalia, fingers, and toes. Now, the nurses from plastic surgery team will be called and advise the patient and their parents on the last meal and fluid before the procedure date, day and time of procedure, if they are agreeable for dressing under GA. At the children emergency, they adopted the protocol of sedation model, and together with the head of plastic surgery team, came up with the flow on burns dressing as seen on this slide. Circled in red are points where doctors prescribe oral anesthesia, pain relief medications for patients to take home. We also work with CE to ensure that the patients go home with the analgesics, are advised to take a dose before reporting to Cleft and Craniofacial Center for their outpatient dressing. The dressings that are more than 4% are done by the plastic nurses when called upon by the CE team and plastic daughter to assist in burns wound debridement in CE. Mitigation for repeated dressings, pain management, and the selection of appropriate non-adherent dressings are considered an integral part of nurses' delivery of care treatment management that is to reduce procedural distress with minimum dressing change. Addressing the interconnecting requirements towards pain relief in repeated dressing, pain management is the main area where we look at pain assessment, pain relief measures, and the collaborative care arrangement. Relevant training and competencies for staff such as BCLS, medication administration, e-learning on managing pain at outpatients are carried out every 2 years. Mock simulations are done twice a year in the unit regimen to risk assessment to ensure the safety of our patients. All new nurses are supervised and trained to carry out wound debridement in theatre and outpatient setting until they are certified competent. They are able to identify depth of burns and the recommended advanced dressings used in consult with the plastic surgeon. They also receive orientation to perioperative PACU and recovery room practice. Operationally, our fasting time, pre-med dosing, and contraindication charts, fasting time instructions are available for reference. Proper departmental procedural documentations are also in place and accessible in our hospital Doctopedia. These too are reviewed 2 yearly. We also conduct regular preventive maintenance of our physiologic machines, the AED machines, and the upkeep of the e-cart, which is checked daily so that they are working well for use or on standby mode. Wound products for burns are readily available with weekly stock take done and used under first in, first out system. This poster is done by one of our core pediatric anesthetists, Dr. Agnes Ng, and is placed in all clinical rooms for reference on revisions of ABC skills. This slide shows a briefing and a mock simulation with scenario conducted by our pediatric anesthetists for all levels of clinical staff in CCRC and dental services. It is our practice in our outpatient setting that patients will be asked for all their pain status. Any rating of more than 4 and above, the registration clerk will have to inform the nurses. As well, patients will be asked of their pain threshold before, during, and after painful procedures. As most of the burn injuries are between babies and toddlers' age, FLEX is often used to assess their pain during procedures. Most of the time, we'll see them squirming and kicking, crying on and off during the procedure. This, however, stops immediately once the dressing is completed. For bigger children, they are able to understand and respond to their tolerance of pain with the use of warm baker faces and numeric pain rating scale. Now, this tool is used throughout the procedure till ends. The patients are told to rate their pain at regular intervals, and we observe that with the use of topical lidocaine gel of 2% applied on the wound bed and peri-wound area, the scoring rating often told the nurses dropped from an initial 7 to 8 to the scale of 3 and 4 midway through the procedure. There are also a small group of these patients who would bargain for dressing to stop and continue when they are ready. Hence, we would cajole, take short breaks in between until the wound is dressed. How do we manage the pain, and what are the patients we do for those with extensive wounds and high anxiety? The pain from the burns can be excruciating, and the pharmacological pain control should be considered prior to dressing change at outpatient setting. The nurses are asked to ask the patient's parents on how the child copes following the burns at home. We concentrate on giving oral analgesics to moderate pain relief, such as syrup paracetamol, ibuprofen, and painkiller morphine sulfate, which is preempted before we perform any wound inspections or dressing. Safety measures before and after providing oral analgesics for pain relief is checking on any possible allergies, the time they last took their paracetamol and ibuprofen, and the possible reaction the child may have after taking the medication, especially on the effects of syrup morphine. The doctors will review and monitor the patient, and we will monitor the patient accordingly before we discharge them from the clinic. Parents are also advised to look for any morphine side effects such as vomiting, constipation, dry mouth, flushing, giddiness, or lightheadedness, including breathing problems, and to make sure they sought medical help. Staff is also to make sure morphine is not given to any babies under 3 months of age. Where the pain is extreme, based on our assessment using Fleck, Wong's, and Baker faces and the pain numeric scale, patients who are very anxious and where parents refuse to offer a GA for dressing change, the nurse in charge for burns will arrange for the pediatric pain team or a child therapist to provide additional support on the day of the procedure. That is, we can call on the pain physician to administer oral clonidine in combination with other pain medication, comfort the patients, and monitor the patient's pain and anxiety threshold during the procedure. The child therapists under the group of CHAMPS program will be involved with engaging the child and providing the appropriate supportive measures before and until the procedure ends. These measures include play, storytelling, as well as music. The use of non-adhering dressings for burns aim towards minimizing pain to patient and trauma to the wound at each dressing change. For example, we use foam dressings, which are non-adherent to the wound surface, painless upon removal. They can also adhere onto the wound bed until epithelialization takes place. This reduces the frequency of dressing change to a minimum of 2 to 3 episodes. Increasingly popular in the management of superficial and moderate depth partial thickness burns are advanced dressing mediums such as BioBrain, which is a biocomposite dressing, ultra-thin semi-permeable silicone membrane bonded to a trifilament nylon fabric. Now, when placed on wound bed, it adheres firmly to the wound and subsequently separates from the wound as soon as epithelialization takes place. For big areas, doctors and nurses will trim off the BioBrain as it lifts off from the epithelialized wound surface. Usually, it takes less than 10 days. Biohydrofiber dressings is composed of sodium carboxymethylcellulose fibers. Although this can be left in place on partial thickness burns and donor sites for up to 21 days, we tend to see our patients initially for 2 times a week before reducing it to once a week or until clinically indicated. Thus, the minimizing numbers of dressing change. Hydrofiber gels on contact with the wound reduces pain while in place and helps to reduce pain and trauma upon its removal. Current practice rhythm, the first line for all burns cases for pain management at our center is to serve 3 standard meds, that is oral paracetamol, ibuprofen, and morphine. That is 30 minutes before we start with the dressing and wound debridement. The application of topical lidocaine gel of 2%, 1 to 2 grams for estimate 1 minute before the burns dressing is done is helpful because the rapid onset effectively help elevate local pain wound. Pediatric anesthetist team will be activated if the burns is more than 5% or for those that affects hands and feet for degloving, and as well as child who is anxious and uncooperative. Another detailed slide on the pain medicines and algorithm applicable in CCRC. Now, the tick boxes are the standard medication given to patient. Medication is ordered for new patients by the doctors or advanced practitioner nurse. Should intranasal imidazole, for example, is administered by our pain physician, lidocaine spray of 1% is used, considering that lidocaine 10% is very bitter for the patient. We do have a small number of older patients who actually do not want the use of lidocaine gel 2% for dressing change, as they associate the initial stinging pain experienced to the burns. This pre-medication dosing algorithm can be found in doctor's orientation book as well as for nurses. The hard copy prints are made available in consult rooms as well as in treatment rooms, where this chart are used by nurses to check against the doctor's prescribed order for its correctness before administering to patients. This reference helps and provides confidence to the nurses in carrying out their duty safely. We also found that the reception to interventions offered to patients are very age dependent, and the nurses have to be sensitive and aware when attending to these patients. For babies, having parents in the room, using the baby nursery songs, their use of pacifiers, favorite swaddles, towels, even soft toys are big help. The bigger children have the need to know what is to be done. They like to ask steps from start to finish. They will express themselves very well and can bargain with nurses on positive reinforcement. Handphones, iPads are good tools for us to use to distract these children who can focus on their favorite video games and music. Importantly, we need to get to know the patient, be welcoming, focused, and friendly, accepting the way the patients behave and act, which is natural when in pain, in order to achieve patient-centric care when repeated dressing is required. So in summary, we are having this protocol of dressing change in CCRC treatment room. So the steps are actually to guide the nurses of what are the measures they have to take from start to finish for these patients. Reference to previous visits are checked on the Citrix system on the documents that we enter by the doctors and nurses, and to inform the patients and caregiver that all the waiting time after we serve the medicine takes about 30 to 60 minutes for it to reach its peak. The time we have is also to explain on how the procedure is going to be carried out to manage the patient's and parents' expectation. We also include explaining to the parents that we will use an application of topical anesthetic gel to help numb the wound prior to the debridement and dressing change. Where patients is not available to tolerate dressings and is highly anxious for subsequent dressing change, GA is advocated to prevent the patients to go through procedural distress. And with that, I'd like to thank my department of plastic surgery, CE, the pain management team, and physicists, pharmacists for empowering and supporting the plastic nurses in this nurse lab program. Thank you.
Thank you, Ms. Corinne Low, for such a nice and elaborate presentation on the repeated burn dressing on pediatric patients. Thank you for sharing your precious experiences and nice presentation. Now the floor is open for Q&A sessions. The related questions will be highlighted by our moderators and directed to the related speakers. Thank you very much.
Thank you very much, Dr. Ritu, for opening our Q&A section and our panel discussion. We understand that you have some questions in our Q&A chat box. We will ask them later to our speakers. But first, my first question is for Sister Corinne. Hi, Sister. How are you?
I'm good, thank you.
Okay, my first question actually is regarding patient selection. I understand based from your presentation is that there are some group of patients that you can do in the clinic, and there are some group of patients that you go to the operating theater, right, and conduct it there in the operating theater. So can you highlight to us, especially for those who are listening who doesn't have this protocol yet, what would be the best best patient selection? Then after that, I have a follow-up question.
Okay, I'll try on this. We actually have a workflow very clearly indicated on our burns guideline by our head of department. We spread it out like those that is under 4% and those that is above 5% or below 10% that is for outpatient. But more importantly, we actually look at the type of burns, the information that we derive from the system, as well as from children emergency, the doctors, and from our doctors on call or our advanced practitioner nurse, because they have photos to show us These are very strong images that can make us decide whether this is truly a superficial partial burns that we can do at our center, and with the use of topical lidocaine gel as well as the pain medicine. While for those that is looking with deeper partial burns, whereby you see a lot more white leathery color on the wound bed and stuff, we actually will encourage them to go for general anesthesia, because we need to do scrub down as well as to see at what level the burns is.
I see. Then what is the difference? Let's say if you conduct this in a clinic basis, matter of monitoring approach, right? Give us a few difference in terms of those things in a clinic basis and the GA in the operating theater.
Okay. For the clinic, when we are doing procedures, be it whether we are giving the standard medication or be it that we have our patients that actually have oral clonidine for help, we normally will monitor them. It's quite basic, because most of the time, if it's under 4%, it's quite straightforward. But we'll make sure that we have our physiologic machine available in case patient have any drug reaction, a mild drug reaction, especially for morphine, where they tend to vomit or feel giddy. We find that we have a recovery bay, and we have the monitors and the SO2 all fixed on the patient, and we keep them on for about half an hour to an hour until the patient is really good to go. Yeah, but in theater itself, if we select the patients to go into theater day surgery, it is very convenient for us, because we have the team of recovery nurses, PACU nurses, to help take over when we have finished with the dressings. Yeah.
Thank you very much, Sister Corinne. Then you mentioned earlier on that you escalate and activate pain team, right? Whenever is necessary. Now I go to Dr. Serene Lim. Hi, Dr. Serene. So if, let's say, for example, Dr. Corinne, Sister Corinne call you, or I need help, and a pain team has been activated, then what will be the first response in terms of pain management or assistance that the pain team provide for the burns team? Yeah. Dr. Serene? Yes.
Let me just unmute myself. Yes. Hi, thanks, Teddy, for that. Usually we work very closely with Corinne, and then it's usually the more severe burns, the younger children that need repeated debridements, that we tend to put on our service. And we do that with a variety of like NCAs and PCAs for the older children. And then we also have that going into theatre when they have their GAs. By and large, the general anesthetics are for the very anxious younger kids who have a lot of anticipatory pain, at least for the first few episodes, so that they gain a bit of trust and not so fearful, they're not so traumatized. So there are, I would say, two groups of patients. Probably those that you see in the day surgery unit for scheduled debridements, where we do a GA and we try to ensure that when they leave, they have adequate analgesia as well, and that's managed as an outpatient. And then we also have the inpatient kind of group of cohort that we see that we need more specialized management. Does that answer your question?
Yeah, it did. If, let's say, right, if you are, we are talking about multimodal analgesia at this point in time, is there any difference in terms, you mentioned about two types of patients, those will be being treated as an outpatient and those being treated as inpatient. In terms of multimodal adjuvants, choice of adjuvants for inpatient, or choice of adjuvants for outpatients, what will be your preferred medications? Do you prefer to give gabapentin straight away, use ketamine straight away?
Okay, so for the outpatients, we're also mindful that they go home. It's more like an outpatient, almost. We used to do it like an office-based, but now it's largely like in our theater. So it's largely morphine syrup-based with a bit of NSAIDs and paracetamol. And then if they're really very anxious, then a dose of clonidine. We found that quite safe. We are very fortunate to have clonidine. So it's good for sedation. It also reduces the opioid requirements. So as an outpatient basis, I would say clonidine. On an inpatient basis, if they are like in ICU and then you virtually have to do, like at the extreme end of the spectrum, there are those that need virtually anesthetic on the ward for their debridements. We've had like really, really severe burns. And then those will probably have a mixture of like propofol, airway management, and then those will be on gabapentin, the NCAs, and then we will also PCAs, and then that cohort of patients out of the ICU and HD, we generally have an ultra low dose ketamine going.
Yeah, thank you very much, Serene. Dr. Viva, Dr. Joe, any questions for our speakers?
I think there's a question on ketamine because Dr. Serene ended with ketamine. If I could just continue there. So ketamine, I know in my country is used extensively, not just for separation, like Dr. Pradeep has mentioned, but also used intravenously for burns dressing.
Yes.
So I saw oral ketamine also mentioned in Sister Corinne's talk. So could you just explain when would you give intravenous ketamine? When would you go for oral ketamine? Does it delay the recovery in these children?
Okay, so actually, if you have a child that doesn't come in with an IV, you can actually give either intranasal through the mucosal atomizer device, or you could give an oral ketamine dose. And of course, the dosages are a little bit different depending on the routes. If you use the intravenous route, and it's like essentially dissociative analgesia induction dose, it would usually be about like 1 to 2 milligrams per kilo. But if you give it like an intranasal, I give between 3 to 5 milligrams per kilo. In terms of the ultra low dose, that is essentially an analgesic adjuvant that we use, because obviously with the NMDA antagonism, it actually is very, very effective in both reducing the amount of tolerance, because the severe burns we've had have been drinking morphine through the NCPCAs, you know, especially if it's for weekly dressings for as long as a month. So for those, we will use like ultra low dose or even move on to low dose ketamine.
How about clonidine, Dr. Serene? If you mentioned earlier on that you are prescribing it as an outpatient, right?
Outpatient, I would go up to about like 2 mics per kilo. Obviously, if you have a 3 mics per kilo, you have better sedation, but it's actually quite prolonged.
The 2 mics per kg is intra-op use or for take-home medication?
You can use it for pre-medication as well as intraoperatively in the recovery. Okay, so it's actually, if you're using it as a pre-med, we use it actually for dressing changes and stuff like that, like our hypospadias as well, just to digress. And I will go up to like 1 to 2 mics per kilo orally before with an opioid like oxycodone or morphine. And they actually tolerate the painful procedures quite well if you give it 1 hour to work. If you're talking about a kid who's like really a little bit anxious in the PACU and you've given your opioid, but you're deciding whether to give some clonidine to improve the sedation profile or the analgesic profile, at the end, then I would give like 1 mic per kilo.
All right. Thank you very much, Dr. Serene, for that. I think let's move on to craniosynostosis. I think there's a question for Professor Ina. Hi, Ina. How are you? Yeah, hi. I think there's a question, Dr. Ekta, regarding your experience about maintaining euthermia, your euthermia management for patients with craniosynostosis. Can you elaborate on that? What's your practice? Yeah.
Thank you, Ekta, Prof. Ekta, for that question. Maintaining normothermia in this sort of surgery starts from the beginning, actually. So we have to be very meticulous from the start. In a smaller baby or even in bigger children, it starts from preoperatively when I start warming up the theater to the appropriate temperature, you know, and then be very meticulous when we're like looking out for doing the intubation and IV access, putting the IV access. We need to ensure that there's always radiant warmer on top of the children and keep the children warm practically. So it starts from the beginning. And then after we have achieved all that, in our center, we meticulously wrap them with Autobahn, which is like a layer of cotton, you know, to prevent any contact heat loss. And then in area where we think that the surgeons can wet the children, we will put plastic on top of that. So it prevents anything wet to fall on the patient throughout the operation, because the operation can be a long duration. So if there is any wet things around, and then the heat will be transferred to this area of damped, you know. So in a simple craniosynostosis, it shouldn't be a big issue, because as you can imagine, the patient will be covered and only the head is exposed if you have meticulously draped them from the beginning. But in an operation where you can get up to 500% blood loss, then that can be an issue. And we will meticulously warm up all our fluids. But if that still couldn't help, then most of the time, that's one of the reasons we need to send them to PICU for further stabilization.
Yeah, thank you very much, Prof. Ina, for that answer. Yes, it's very clear, and it is also important. I have one more question regarding craniosynostosis before we move on to Dr. Apples. Regarding blood transfusion, do you have any, let's say, set of criteria or set of numbers you have in your practice to decide when to transfuse for patients? I'm sure you have given us all the details on how to prevent the bleeding, give preventions and all that, but in the event that you need to transfuse, what will be your patient criteria? Can you share with us, Prof. Ina?
Previously, we actually look at because we have the outline, so we can do multiple blood sampling. As I said, in a normal otherwise patient, we can bring down the hemoglobin down to 7 to 8, as we want to. And in my center recently, we have used ROTEM to guide us to look at all the blood products that we need. So we no longer use certain sort of protocol, because I think we are now evidence-based. So we use the ROTEM to guide us on which sort of blood product we need. But I think, again, as I told you, preventing is important. So we give the tranexamic acid, and then we add on the infusion dose. And then we have to meticulously work close with the surgeon to ensure that they maintain their hemostasis well. The problem, I don't know if that answered the question.
Yes, it did.
I sort of derived to cell saver and all that,
Goal-directed fluid management and blood transfusion is very clear from that answer. Yeah.
I think it's very difficult to say a ratio of platelet to cryo to fibrinogen, because the evidence is more now to say that it's not relevant so much, So I'm glad I have ROTEM in my place, and we are always goal-oriented. Yeah.
All right, thank you very much, Prof. Ina. Now let's move on to Dr. Apples. I mean, if you look at the Q&A box, we have a lot of questions about airway management regarding the Kopur scoring system. Do you mind, Dr. Apples, share more with us? I think you have answered a couple of questions in the chat box, but
I think,
yeah, what is the value of Kopur in our practice? Are we going to use it as a standard as a replacement to Malampati, or yes, please kindly enlighten us.
Actually, for children, Kopur scale or index is used for children, especially for syndromic children. So it's more of observational. So especially if we have non-cooperative patients, like for the chin, we could see it. For the mouth opening, we could see it. We can observe and then just put the score. With the history, with the history of OSA or previous intubation, that we can ask the parents. Then for the uvula, we can see it if the patients cry, even if they are not cooperative. If they cry, we could just peep on it. And the R is actually the range of the head movement. So the angle there is the orbit is the R index. So when we go up and down, that's the range. So if you notice, the 120 degrees is the movement of the head going up and down. So if the patient has some form of limitation of the neck movement, the patient will just move a little like that. So either the parents can ask them to do it, or we can just observe. Now, it is recommended for patients with pediatric patients who are syndromic. Yes.
Thank you very much, Dr. Apple, for that answer. I think going back to one of the things that you highlighted during the talk about throat pack, you actually presented different evidence, comments, suggestions about throat pack. Now that we have microcuff available, right? And more and more people having questioned whether there is a value of throat pack, or should I put throat pack? Whether is it a surgical decision? Because sometimes, right, even you feel that You don't need to put in throat pad, but your surgeon will ask you. So in your practice now, both for your hospital and for your mission trip, do you still insert throat pack? Do you still advocate the use of throat pack? So what's the end point or what's the conclusion for this?
Well, as I said earlier, there's no hard and fast rule right now. There is no guidelines as to the use of throat packs. It's more of the preference. But personally, I would still use it, although some surgeons would like to avoid using it, especially for palate, because it goes in the eyesight of their surgical field. And with the use of microcups, so we can protect our airways. Maybe we could suction all the blood and everything just before we wake up the patient. So the problem of having ingested blood or blood in the throat and in the stomach is, we can deal with it by suctioning it properly. So will I recommend it? It's still up for debate.
Thank you very much, Dr. Apples, for that answer. I
just have a comment in addition to Dr. Apples. I think it's important to know that even though some of us may not use throat pack, but I think it's still important to check, because sometimes surgeons do put in packs as well. So I think it would be the responsibility of the anesthetist just to check before extubation, even if we had not put in a pack.
Yeah. That's a good practice to do a laryngoscopy and check before you extubate the patient. And I think sometimes, right, correct me, Sister Corinne, if I'm wrong, we actually include the pack in our swab count so that there'll be a counter check from the nursing side, whether the throat pack is still inside the patient. All right, Sister Corinne, another question. There's a question here asking about topical lignocaine. When do you apply it? I think you mentioned that you apply it before, but you mentioned that there are some patients who actually refuse it. Can you actually expound on that point? Yeah.
Okay. In general, most of our patients, we apply the lignocaine gel 2% before. That means as soon as we open the previous dressing, we will actually put a dollop of it, let it wait a while before we smear it around the wound bed. Patients are most of the patients react very happily in the sense that they're very relaxed when we are doing the dressing and when they are done and covered. But yes, there are bigger children. Actually, the bigger children are the one that actually complains about the lignocaine gel, because once you put it on, they tend to get a bit of the smarting, stingy pain, and then they say, okay, I don't want it anymore. So they totally reject the use of lignocaine gel. So we have to be very fast when we do for this. I mean, we have to respect their wishes, but we have to cajole them or take any other measures in order for us to carry on with the wound dressing.
I see. Thank you very much, Sister. Then you also mentioned about CHAMPs or non-pharmacological approach for this group of patients. And I think most of the time, it's more of the preparation rather than the actual wound dressing is actually very important.
Yes.
I know that we have a lot of medication. We have all the armada of different types of medication, but at the end of the day, it's a non-pharmacologic approach is really one of the helpful things that we can use for them. There's a lot of question in the chat group regarding about the use of ultra-low dose ketamine, if you use IV midazolam. I think Dr. Serene answered those. Maybe Dr. Serene, just a quick summary regarding the use of midazolam, ketamine, tramadol combination or infusions that you answer in the chat group, just to
Okay, so it's very resource, practice, and preference based. We tend not to use a lot of tramadol. We think that it has quite a bit of nausea associated with it. And we have the stronger opioids. To answer your question, for midazolam, if you're going to send them back, I think clonidine has a better profile, safety profile. Midaz can also have a, what do you call it, a paradoxical kind of like excitation kind of manifestation, pretty much like when you have a happy drunk versus a belligerent and a totally wild drunk. We tend to use, like, to summarize our practice, we have the outpatients. So those are usually oral based. We only give the opioid as a regularly for the first few days, and then we give it PRN. or it's an in-hospital base, in which case we usually give on the wards, they have the options of oral opioids and IV morphine. You can layer on a ultra-low dose ketamine to make the pain relief better. And we usually slide in champs there because then that's better for the kids. Then the more complex ones where we actually layer on both the IV ketamine and the gabapentin and the clonidine and on top of champs. I think the main thing to bear in mind is do not traumatize the kids, because it's the anticipatory pain that makes it go out of control, spirals out of control. So once you get the trust and you've given them good analgesia, then they're more likely to cooperate with you for future encounters.
Yeah, I agree with that. In fact, on top of that, I think parental involvement is very, very important, because you need to involve the parents in this management, because they'll be the one accompanying the child in whether it is a clinic basis or a GA basis. Now let's move on. We stick to pain management, but we will move on to craniosynostosis post-surgery pain management. I understand Prof. Ina shared some some lists earlier on about the use of Panadol, NSAIDs, and oxycodone. Do you actually consider using NCA or nurse-controlled analgesia or morphine, or you stick to oral because they'll start feeding immediately after all?
In our center, Teddy, we don't have NCA. So if you're going to use, it's going to be PCA. And as you can see, most of the children that undergo craniosynostosis, they comes at a younger age. So if it's a massive, if it's a big repair, then I will go with IV morphine infusion, and they'll be monitored either in HDU. But surprisingly, if it's just they can be easily converted to oral with oxycodone, and also on the first few days with IV paracetamol.
Yeah. So if oral oxycodone, right, what is the usual dose that you start the patient with?
I usually start in between 0.1 to 0.2 milligram per kilo, and for hourly, regular. Yeah.
Yeah. All right. So, Dr. Serene, another point of view from same question, pain management for post-craniosynostosis surgery. So for your end, what will be your choice of management for this group of patients?
Actually, I don't know whether it's the same for all the anesthesiologists all around the world, but I find that the facial, the head and neck kind of pain is usually quite well managed, and usually they don't really run into much problems beyond the second or third day of operation. You don't find them bouncing back to the pain service, whether it's because it heals so well, it's very well vascularized, or the pain is very well tolerated. I don't really know, but we usually don't really have a huge problem with it. And even simple IV morphine, I think it's enough. It's just important to remember that if they're infants and young, if you put them on IV morphine, not to leave them on like 1 to 2 mils per hour, for 2 days on end, because they're going to get respiratory depression. So it's important to have regular pain monitoring, sedation monitoring, and then you just titrate. If the pain relief is not well controlled with the IV morphine, you can always layer on ultra-low dose ketamine, which is basically the same dilution as the morphine. So it's like 1 mil per hour is 20 mics per kilo per hour. And you'll find that, within 3 to 4 hours, the pain comes right down. So it's a great trick to just layer on.
Okay, for the benefit of our viewers, when we say 1 mil is 20 mics, meaning that the body weight of the patient converted to milligrams in 50 mils. So let's say if you have a 10 kg patient, so that will be 10 milligram of morphine into 50 mils of normal saline. So when you run that to 1 mil per hour, it will be 20 mics per kg per hour. Okay, we do this for less than 50 kg patients. All right, okay, that's to clarify the dosing that we are discussing just now. Okay, I think we have more questions, Dr. Viva, in the Q&A box.
Yes, there are a few. I think there's a question on NSAID use for burn pain management. So probably Sister Corinne could start first.
NSAID use, NSAID, Bufen, or maybe we include those other things like, Sister Corinne?
Yeah, because we only stick to the basics for ibuprofen. When we give the NSAIDs, we always ask the parents first of whether or not the child has any allergy or any medical issues that may affect the child if we do serve the ibuprofen. So ibuprofens are times we actually omit from our standard 3 drugs, that is paracetamol, ibuprofen, and morphine. And we will actually just give Panadol itself without giving the ibuprofen. Yeah, because at the same time, we make sure that the child actually has taken some food so that they do not go into the reaction of having these NSAIDs in them.
And also be mindful about the patient's age, because
yes,
you cannot serve it for less than, some FDA will say you cannot serve it for less than 1 year old, but
yeah,
that will allow it until 6 months. But you need to your dose to 5 milligram per kg rather than the 10 milligram per kg per dose.
That's right, on the low end, yeah.
The low end. But yes, be mindful about the patient's age when you are prescribing NSAIDs. I think there's one more from Dr. Ekta. I think Prof. Ekta just gave us a nice topic to research. So she's asking for do you have any long-term study to see the impact of pain treatment or management for burn children in behavioral changes? I haven't read paper yet regarding this impact. I think because the numbers are not that great, but in terms of observation. But yes, it's a good, Sister Corinne, we can work on this. Yeah, it's a very, very good question, Ekta. But what we actually noticed for our patients is that those who actually went for multiple burn stressing, is particularly those who went for almost every other day or every week burn stressing, is either they will cope up so well that they will actually very good and they will cooperate very well, or they will develop a lot of anxiety that they will require pre-meds before procedure. So there are 2 prongs of patients here, and we need to identify their requirements and address it accordingly. Yeah. Any more questions from the floor? Dr. Joe, Dr. Viva?
Just to add on to that, there is some trauma because there is a very interesting TED talk on this guy that was, he's based on the TED platform, and he had burns when he was a child, and he was trying to bargain with them, you know, because when you rip the dressing off, whether you rip it slow or you rip it fast, and he was trying to bargain that rip it slow, and then he said that the lidocaine was also very, very painful, the 10%, because it's got preservatives. So I think he's an adult and he's very eloquent, so I think the trauma of it stays with you until you are much older.
Okay, yeah, noted in that, Dr. Suri. My last question is for Dr. Apples. If, let's say, right, regarding opioid use, we understand that we have certain dose for opioids and all that. If you are attending or joining a mission trip for a certain remote area or province in one, do you actually cut down your opioid calculation in terms of, yeah, by how much? Can you, let's say, for example, fentanyl? Yeah.
Fentanyl, like for for fentanyl, instead of giving 0.1 to 0.2, I give instead of giving 2 microgram per kilo, I'll be giving 1. And then usually in mission settings, I stay in the recovery room with the children. That's my safe space. So I don't release my children unless they are up and about and pain-free. And regarding that, usually we give a mixed paracetamol and NSAID, either ibuprofen. That's it for oral.
I see. Yeah. So that shows that you really need to you give the smaller dose and you titrate.
Yes. You have to realize in mission settings, we don't know the staff in the wards.
Correct.
So we really need to be very, very careful. And at the end of the day, anesthesiologists should stay behind and check everyone before going home for the day, for missions.
For missions. Thank you very much, Apples. Dr. Viva, Dr. Joe?
Time to wrap up. Over to you, Dr. Joe.
Hey, I think we've come to the end of today's webinar. I would like to thank all the speakers for their very, very interesting talks and the time spent preparing them. I'd like to also thank Teddy, Dr. Ritu as moderators for today, and also Dr. Viva Naik for helping us with the IT support today. And also the audience for staying back with us. Without you, the webinar will not be a successful webinar. So I'd like to thank all of you. And before we say our goodbyes, we just have a few announcements, and Teddy will be helping me with the announcements. Thank you.
All right, so as we mentioned earlier on, certificates, the survey will be launched tomorrow. Please key in your correct name and correct email. Yeah, key in your correct name and email. So you can visit our website, our YouTube channel, and our Facebook page for our recorded webinar. Yeah. Then we would like to invite everyone to attend our ASPA 2022 conference in Istanbul. It will be on the 14th to 16th of October. For more details, you can either check the website to register and follow us on the Instagram page. And then before the actual conference on the 14th to 16th of October, we have a pre-conference workshop. All of this will be virtual. If to know the details, please register and check the ASPA 2022 website and register. Deadline of submission of the registration will close at the end of the month, 30th of August. So one of the pre-conference workshop, we have the perioperative pediatric life support course. This will be online. So even if you cannot fly to Istanbul, you can actually attend through Zoom. So please register. There's a special discount now for non-members. It will be $40 US. And for ASPA, TARD, and ATTD members, it will be $20 US. So please register before 30th of August. And lastly, of course, if you haven't submitted your abstract for the conference, please submit. Initially, the deadline is 15th of August, but now we move it to the 15th of September. So you have one more month still to submit for the ASPA 2022 conference abstract. And included in the ASPA 2022 conference is our Bringing Childkind to Asia. Childkind, by the way, is a non-government organization that provides certification to all hospitals or institutions that have high regards to patient pain. And I think Dr. Serene is one of the speakers for that, Bringing Childkind to Asia. We will discuss here what Childkind stands for, and is it just about doctors or nurses are included, and of course allied health. And Dr. Serene will share our KKH experience in Singapore and what are the things that we done and prepared to become a Childkind certified hospital. And lastly, of course, ASPA's mission is to foster the highest standard of pediatric anesthesia care in Asia. And we are a non-profit organization, hence we seek your help to donate and help us in our cause. For those who wish to donate, please scan the QR code and donate. Or you can also visit our website. With that, thank you very much on behalf of Dr. Joe, Viva, Dr. Ritu, and the rest of our speakers. Thank you very much for listening, and a pleasant evening for all.